Ever wondered how doctors can tell what's wrong inside your knee just by looking at an MRI? Magnetic resonance imaging, or MRI, is a powerful tool in diagnosing knee injuries, but understanding its complexity isn't just a walk in the park. First, grasp the basic anatomy of the knee. The knee joint involves bones like the femur, tibia, fibula, and the patella. Soft tissues such as cartilage, including the articular cartilage and menisci, help cushion the joint. Ligaments like the ACL and PCL provide stability, while tendons connect muscles to bones, aiding in movement. Remember, the knee also houses muscles and bursae, which are fluid-filled sacs that reduce friction. Next, familiarize yourself with the MRI planes and sequences. The sagittal plane offers a side view, splitting the knee into left and right halves. The coronal plane provides a frontal view, dividing the knee into front and back halves. The axial plane, meanwhile, gives a top-down view. Each of these planes helps visualize different aspects of knee anatomy. When it comes to sequences, T1-weighted images are excellent for viewing anatomy and bone marrow details. T2-weighted images are adept at detecting fluid and inflammation. Don't forget about proton density and fat-suppressed sequences, which are crucial in specific assessments. Now, dive into the steps to read a knee MRI. Start with the sagittal plane to check the alignment of the bones and any abnormalities in the cartilage, menisci, and ligaments. Move to the coronal plane to evaluate the menisci, collateral ligaments, and overall joint space. Then examine the axial plane to focus on the patella, quadriceps tendon, patellar tendon, and the trochlear groove of the femur. While navigating through these planes, use different MRI sequences to confirm findings and understand the nature of any abnormalities such as inflammation, tears, or fluid accumulation. Be on the lookout for common abnormalities. Meniscal tears might show increased signal intensity or displaced fragments. Ligament tears, particularly in the ACL or PCL, might present disrupted or wavy fibers. Cartilage damage could appear as thinning or fraying. Areas of increased signal intensity on T2 or fat-suppressed sequences could indicate bone edema or contusions. Also, watch for effusions, which are abnormal accumulations of fluid in the knee joint, and conditions like cysts and bursitis. However, interpreting an MRI is complex and requires expertise. Always consult a radiologist or a medical professional trained in imaging for a detailed and accurate diagnosis. In conclusion, reading a knee MRI involves recognizing normal anatomical structures and identifying deviations that suggest pathology. It requires a systematic approach and, ideally, guidance from experienced professionals to ensure a thorough and accurate assessment. Remember, combining these imaging findings with the patient's symptoms and clinical history enhances diagnostic accuracy. So, while the MRI provides the images, the full picture comes from a comprehensive clinical understanding.